So yeah, I'm just going to start sort of by presenting a case of an upper GI bleed that we saw sort of back in August time, to kind of get everyone thinking a bit before Dr. Mayhead goes through sort of in more detail the management. So yeah, go to the next slide. So this chap is a 48-year-old who came into A&E with an episode of melena. He noticed one episode a week ago, but today was sort of a bigger episode of sort of black high stool. And in A&E, he vomited about 500 of a coffee ground vomit, and he just had some abdominal pain. So at this time, obviously, you're thinking of an upper GI bleed. We're not really sure yet what could be causing it. The next thing I sort of always think about is, could this be a variceal bleed? Mainly because they can be a bit worse, I suppose. And obviously other causes would be something like a ulcer and things. And then you sort of delve into their past medical history a bit more. So if you go on to the next slide, please. You can see that this chap does have a background of liver disease, and you also note from well, he tells you that he's had a previous variceal bleed before, where it was found on OGD that he had grade 3 varices and he had 4 bands. And that's his other past medical history there, nothing else that's significant. And then if you go on to the next slide, you can see that he has previously had a background of alcohol excess, but he's not drank anything for 7 months, apart from 1 beer, he said. He obviously has a 20-pack year history. He's independent, lives alone, and those are his drugs he's on there, and he's allergic to penicillin. Nothing else really to note. And then you go to examine him. So on the next slide, obviously, luckily, this chap is hemodynamically stable. His blood pressure is okay at 120/64. He's a bit tachycardic, but he's alert. He doesn't look that unwell when you just sort of examine him. He's a bit dry, but his capillary refill is okay. You notice he's got a big abdomen that he's had drained. He's had some ascites drained in the past. Everything else is there. He did A&E did a PR, which did confirm melena, but there's no fresh blood. And ECG was done as well, which is fine. So you take some bloods, and they show. Oh yeah, next slide. Thank you. Also, you can feel a bit okay. His HB isn't too bad. It's 102. Slight urea increase, but not too bad. And the rest of his bloods is done. His INR is okay. And it's just important to remember to do a group and save in these patients, because they are likely they may need some blood. And then the other useful thing you can do in A&E, if you see a sort of query after GI bleed, is you can do some of these scores. So if you go on to the next slide, most people know about the Glasgow-Batchford score, which is just a useful kind of tool to stratify patients who come in with upper GI bleed in the emergency department who are sort of low risk, that may be for sort of outpatient management, or patients who are more high risk and will need sort of hospital admission. So I put this chap's details in, and as you can see, it just says that he has a high risk, which usually is, if they have a hepatic disease history or a liver disease history, and there's confirmed melena, it gives them quite a high risk. And then you can also do a Rockall score, which usually the proper Rockall score is done after endoscopy. It kind of determines severity again, rebleeding risk and sort of mortality. But there is a shorter one you can do prior to endoscopy, which again just helps to sort of determine the severity. And you can see this chap, when you put his details in, he's got a 24.6% mortality prior to endoscopy. So anybody who, he will need admitting. So the sort of plan for him on this when he came in the evening. So if you go on to the next slide, the plan for him was sort of give him terlipressin and cefuroxime, which is given to anyone who you think may have a variceal bleed. So I'm sure Dr. Mayhead will go into this a bit more, but I think terlipressin, the way it kind of works is it's meant to vasoconstrict the splenic artery, so kind of reducing the blood pressure in the portal system. And you give cefuroxime to anyone who might have a variceal bleed as well, because I think studies have shown that people with variceal bleeds sort of have a predisposition to infection as well, and giving antibiotics improves the outcome. And the same with PPI, just helps to sort of try and reduce the bleeding. And then plan was for an OGD tomorrow. So then he had an OGD the next day, and again it showed a couple of grade 3 varices which were oozing blood, and it showed sort of recent signs or recent bleeding present, and 5 bands were applied. Go on to the next slide, you can just see some photos of what the different grade of varices look like. So obviously this first one has no varices, and then you can see in the grade 1, it just looks like a varicose vein really, sort of at the top of the picture. If you can see that, I don't know. And then again, you can just see it getting worse and worse. So he had these grade 3 varices and the bands were applied. And usually that's fine, that's banded, and then obviously you keep them in, repeat their bloods and make sure everything's okay. And this chap went back to the ward after his OGD, and then you get a bleep in the early hours of the morning about this chap. If you go on to the next slide, and you get a bleep about a large episode of melena after this first OGD where he had the bands applied, and he looks a lot worse. He's a lot paler. His blood pressure has gone down to 99/61. His other observations are fine. You start looking through the notes and you realise that he's just had ongoing melena all throughout that day, even after the OGD and into the night. So if you go on to the next slide, you can see that this is actually, I managed to get this from his notes, and you can just see that even after his OGD on that day too, he's just had consistent sort of incontinence of black tarry stools. And he doesn't look that great, so you sort of get the med reg involved. And then if you go on to the next slide, what they did was they sort of did an ABG, and his HB went down to 61. So obviously it was up in the hundreds before. Do a formal set of bloods, and this chap obviously as a 48-year-old man, so the decision was made he would be for full escalation. So I remember CCOT came to review him, and at the moment he was sort of responding to fluids overnight, and the med reg kind of discussed with the gastro consultant on call overnight, and the plan was sort of heat nil by mouth, and he'll need a repeat OGD in tomorrow, so the next day. And then if you go to the next slide, you can have a closer look at his blood. So on day 1, when he was first seen in A&E, the bloods taken showed that his HB was fine, 100, and his urea was okay. And then he actually, looking back through his notes, he actually had bloods taken when he got back from his OGD, but they sort of only came back at sort of 11:30, midnight. But that actually showed that his HB then was 60. And then I think someone had seen it and written him up for some blood to go through. But then when he got the bleep sort of in the early hours of the morning, when he was more unwell, obviously you can see the HB has dropped a little bit again. So I think he had 4 units overall. And then as you can see, his bloods and the urea went up as well. And as you can see, the bloods sort of then start to get better. So then he went for his OGD on day 3, so the next day. And if you go to the next slide, please. Go to the next slide.
Thanks. I have. Can you not see
it?
No.
Thank you. So that is an actual picture from his OGD that day, and you can kind of see, I think, hopefully, the band around that varice there. It just showed that day that there was 4 bands that had, stayed there from yesterday, but that one of the bands had slipped, and a further 3 glands were placed. So I suppose from this kind of thinking, he's had 2 OGDs, he's had bands. what would happen if he had a further bleed again? Could he go for another OGD? And I think after this OGD, it was kind of considered that if he did have a bleed, you might have to think of, you know, something else. And they sort of considered what is called a Seng Staken tube, which is that picture there. And it's kind of like a cross between a three-way catheter and an NG tube, where it's kind of used in a way that it goes down and then the gastric balloon is first inflated, and sort of the pressure, the compressing that GOJ is meant to be enough to sort of reduce blood flow to the varices to try and help stop bleeding further. And then if just the gastric balloon doesn't help, then you can then inflate the esophageal balloon, which again is just there to try to compress them and stop blood flow to the varices to try and stop them bleeding. But obviously that can't sort of stay in for too long because you don't want to cause any necrosis. So that was sort of considered if he did rebleed. Or the other thing would be for away tips, which would only be done at King's. And then this again is just sort of a shunt that's put between the hepatic vein and the portal vein, just to try and lower the pressure in the system and trying to reduce the blood flow to the varices to stop the bleeding. Luckily, this chap didn't need to have any of those because he stopped bleeding and his HB started to creep up, which is good. And then if you go to the next slide, we did his Rockall score sort of after endoscopy. And this shows that obviously with this chap, he is going to have a really, if you put in all his numbers, you know, his less than 60, he did have hypertension the second time round, he's got liver failure. And it was seen blood in the upper GI tract that actually he has a really, really high risk, or sort of 41% rebleeding risk. And what's interesting about this chap, so this is his admission in August, but if you go on to the next slide, he's actually a chap who has had 6 bleeds sort of coming into hospital over the past 4 months. So, you know, that is true. He's had a lot come in a lot of times. You can see sort of in September, October, it's grade 1, and then they sort of go into grade 2 and have been banded. And then the most recent time he's been in December, you can see that sort of all the bands have come off and he's got healing sites there. And then sort of, I don't think he's come in, as far as I'm aware, I didn't see that he's come in since December, but kind of what's his plan now? Where is he going? If you go on to the next slide, I think since when he was discharged, obviously every time he's discharged, he gets booked in for a surveillance OGD in 6 weeks' time to sort of monitor the varices. But I don't think he's ever actually had that because he's come in before then bleeding. But that's sort of the plan from now. And I think he's being considered for a liver transplant at King's. So I think he's being worked up for that at the moment. But yeah, that's him. Just kind of interesting of someone who, just a recurrent variceal bleed, really, for someone who's quite young and was quite unwell with it a few times. Yeah.
Indeed. Thank you, Alice.
That's all right.
Indeed. Are there any questions from anyone before I do my little bit? Doesn't sound like it. Okay, well, no worries. Shall I take over?
Perfect.
Okay, let's see if I can project my presentation. One minute there. Can that be seen?
Yes.
Fabulous. All right. Sorry, I'm just going to bring it up on. Okay. Well, as Alice pointed out, GI bleeding is not always straightforward. In that presentation, you obviously the gentleman had a number of bleeds, and unfortunately, people do still die from gastrointestinal bleeds or have serious morbidity and morbidity and all mortality, I'd imagine, is serious. So moving on, so I'm going to cover a little bit about the endoscopy and the management of upper GI bleeding from the point of view of yourselves as junior doctors looking after these patients. So it's not all just about the actual endoscopy itself, although that's we can do some clever things with a scope. From your perspective, it is getting the patient prepared and ready for the procedure. So I will talk a little bit about a bit of an overview of GI hemorrhage, pre-endoscopy preparation. I'll show you a few pictures of bleeds and a little bit about the kit that we use, and then aftercare following a GI bleed as well. So there's been some publications these are a little old now, they're not so recent, but there hasn't been anything since these ones were published. I think the most recent one is about 5 or 6 years ago, but GI bleed, there hasn't been really any major updates in the management of GI bleeds in recent guidelines that have come up in the last few years. The incidence of this is about 100 per 100,000 cases per year, and there are about 4,000 deaths in the UK per year from GI bleeding. There is a 10% mortality rate. Right, well, I'll carry on then. So recent publications, so we touched on that, and the incidence is around about 100 per 100,000 cases per year with a 10% mortality rate, which hasn't really changed an awful lot. One has to bear in mind, given when you're on the wards, that the actual mortality rate for established inpatients is much higher than someone presenting at the front door, because these patients often, if you have a patient, an elderly lady on the ward with a fractured neck of femur that you're asked to see who's had a GI bleed, they have multiple other comorbidities, and so their mortality rate is quite a lot higher. So what's the etiology? What's the general causes? So about a third of cases is acid related, or is peptic ulcer, and then varices is actually only about 10%. And I think perhaps it's important just to realise that no cause is found in nearly 1 in 5 cases. So we have a lot of patients who come to endoscopy, and a lot we don't find what the cause is in a significant percentage of patients. But you'll see on these these statistics that a lot of these patients have just inflammatory acid-related problems, as opposed to actual ulcers and breaks in the actual lining of the stomach. PHG is portal hypertensive gastropathy, by the way, related obviously to cirrhosis. So pre-endoscopy preparation, risk stratification is important. Who do you want to scope first? Who can wait? There's resuscitation of the patient. So that's actually more important. So the reflex reaction just to call the endoscopist is not the right first thing to do. The first thing to do is just to sort the patient out and get them into a stable situation so that we can scope them safely. If the patient is crashing because they're bleeding, an endoscope is not going to fix them. Where and when and with whom? Well, it is better to do these patients, much like the people have decided with emergency surgery. If it can happen in the day, do it in the day. Don't do it at night time. Sorry, it's my cat. If anyone who's wondering what that tail is. So doing it during the day if you can. It's much better to scope a patient in daylight hours than doing it at 3 in the morning if you don't have to. And indeed, since we've had a 24/7 GI bleed rota until COVID sort of closed down a lot of the weekday on calls, I think we only came in about 2 years, about 2 or 3 times overnight. We generally try and get these patients done during the day. And of course, where to do it, ideally you want to do the endoscopy unit, but it's important that to protect patients' airways. So sometimes patients with massive GI bleed where there's a lot of hematemesis, you may want to take that patient to theatre to scope the patient. So all these things just need to be considered, and of course one has to consider what to do with all the anticoagulation and blood drugs that the patients may or may not be taking prior to a procedure. Do you leave them on their antiplatelets if the patients have coronary stents? And so all these things just need to be considered. As Alice pointed out, there is a Blatchford score, and the Blatchford score can be used. It was a score that was originally designed to estimate risk and could you potentially discharge a patient home with a GI bleed. And indeed, logically, if you have the more points, the more risky the patient is. If the patient has a score of 0, it's quite possible that they can go home and have an urgent GI bleed endoscopy as an outpatient within a couple of days. And of course, there's the Rockall score, which was not designed as a sort of a risk stratification, as a risk stratification for endoscopy. It was designed as a mortality to assess mortality. Rockall was actually a surgeon in Guildford who came up with this score quite a few years ago now, I think in the 80s. And as you can see, the more points you get pre-endoscopy, the higher the risk, and we generally have a score of 4 or more is someone that you might want to scope, as soon as you've resuscitated the patient. As you can see, the higher the points, the more problems that are occurring for that patient. So why do we do this? Well, the Rockall score, as you can see, as Alice pointed out, the more points you get, the higher your mortality rate. So if you have a pre-endoscopy score of 7, then you've got a 1 in 2 chance of dying from that GI bleed. If you've then got a score, if you can see, if you're at the extreme, if you've got a score of 8 after the endoscopy, then you still got a 40% chance, even if the endoscopy's been successful, of dying post-procedure. And equally, if you've got on the opposite end of the scale, the score of 0 or 1, a very, very low chance, or even 2, a very low chance of dying post-procedure or post-endoscopy. So, do we give PPIs to everyone? Well, we generally do, but there's not a huge amount of benefit. There's reduced, depending on your point of view, there's less endoscopic therapy is required if you give a patient a PPI. Pre-procedure, prokinetics, if you give patients erythromycin or metoclopramide ahead of the procedure, you get a clearer views, but there is no clinical benefit to that. So for patients with a low risk score, I've already alluded to this. Is there any need for admission at all? It would be fabulous if we can get these patients home and then into an urgent scope. Again, with the pressures on endoscopy, doing a scope at 3 or 4 weeks after a GI bleed often is quite pointless. Whatever's caused the bleed is not. It's probably gone away. So you still want to scope these patients soon, but they do not necessarily need to be inpatients. So when do we scope patients? Well, the guidelines would suggest that all patients are offered so high-risk patients are generally scoped immediately after resuscitation. So someone with what you suspect is a massive variceal bleed, if you've resuscitated them, you won't want to offer them a scope as soon as possible. Those are the types of patients you may want to come in the middle of the night for. Do you offer, and all other patients, the guidelines are that they should be scoped within 24 hours, which is often a challenge from a logistical perspective. But that is the general guidelines for these patients. So why do we do endoscopy? We know it improves the outcome, and we want to rule out varices because obviously the treatment for varices is quite different than it is for peptic ulcer disease. So for anticoagulation and antiplatelets, correct the INR. If the INR is greater than 1.5, consider the indication for the blood thinners. Do you need to keep them running because they've got a high thrombotic risk? It might alter the timing of when you might want to do an endoscopy. But clearly, if bleeding is the primary issue, then stopping the medication has to be the primary thing that you do. And then there's things like bare metal or drug-eluting stents. Again, patients on clopidogrel or prasugrel, it may well be that you need to leave them on those drugs and get on with the endoscopy because actually the risk of coming off those drugs is quite significant. You can transfuse platelets to reverse the effects of these agents, but obviously if there's a good reason for them being on those drugs in the first place, one does have to be careful, and it is a real risk. We have had several recently, we have had several elective patients in for normal scopes who have had a TIA because they have been taken off their blood thinning agents ahead of the endoscopy. So it does happen. We've just had a couple recently, which has just highlighted the point of having not had much of that sort of problem for quite some time. So do we resuscitate the patient? Yes, stabilize them with crystalloids and bloods first. Avoid the knee-jerk reaction to call the endoscopist, as I said. Do make sure that it's a large bore peripheral cannula. These patients don't need central lines or anything like that. They need peripheral cannulas and lots of fluids to get their blood pressures back up and under control and get their hemoglobin above 80 generally. So intubation prior to the airway, again, this is important to consider when you're prepping a patient for a scope. If the patient has active hematemesis, as opposed, or their GCS is compromised because of encephalopathy, then those are the types of patients that may want to have their airways protected, because actually blood in the lungs tends to kill people, and is generally a bad idea. So for varicose bleeding, Alice obviously touched on terlipressin. It is a vasoconstrictor, as it reduces pressure, and it is a very important, that and antibiotics is a very important aspect of the management of these patients, because they can get spontaneous bacterial peritonitis, and having bugs in the blood alters the hemodynamics in the splanchnic circulation. Excuse me. The other things that one can consider is Stark and Blakemore tubes. I don't know whether any of you have come across them. That's balloon tamponade. That's something we do have at the trust. These are fairly brutal looking devices which can be passed into this patient's stomach, and the balloon blown up in the stomach to apply pressure to the veins coming up, the azygous veins coming up from the stomach into the esophagus, and that is a good way of temporizing things if you haven't got access to endoscopy, or indeed if endoscopy has not been successful. TIPS, as you may or may not know, is not available locally. It's something we would have to transfer out to London for. It is essentially a shunt between the portal vein and the IVC, which reduces the pressure significantly. The downside to it is it can cause quite significant encephalopathy in the longer term. So it can be life-saving, but equally it can cause significant problems, and it is often a prelude to a liver transplant at a later date. Varicose bleeding is a cause of death. Is the cause of death in a third of patients with cirrhosis. It's important to understand these statistics. Actually, the mortality rate of patients who are bleeding in a Charles Pugh is around 20 to 40% overall. If you've got someone who's got a child Pugh A, in other words, a stable cirrhotic, the mortality rate's around 10%. In someone who's a decompensated cirrhotic, the mortality rate is around 70%. So the varices do not bleed until the pressure within the portal system increases over 12 millimeters of mercury, and 30% of patients with large varices will bleed within 2 years. So it's important to remember these sorts of statistics. Perhaps if you're discussing the relative risks and merits of endoscopy, or the risks of intervention prior to us scoping them, or indeed if you're managing these patients on the ward, it gives you some idea of just quite how unwell these patients potentially can be. So varices. This is a bit like the pictures that Alice put up earlier. These here are these very large serpiginous varices. You can see that there's blood here. You can see potentially here where the cursor is that there is a little red spot, perhaps where there has been a bleed. So this is the sort of thing that you like when you're an endoscopist, is this sort of thing. You go exactly where you're going. That's a spurt of blood, obviously coming from a varix. Putting a band over that, makes all the difference. And what we have, here we go, this is the type of stuff that we attach to the scope. This, you can see here, they've got 7 bands that are attached to this little device that we put on the end of the scope. So we go down with an endoscope and we have a look around and decide the patient has got varices and therefore we need to band them. The scope comes back out again, and then we attach this device, and this has a pull cord that runs up the biopsy channel to the to this little handle thing here that sits on the end of the biopsy channel, and you can fire off up to 7 bands in this device over the varices to stop the bleeding. They are the downside to these sorts of things is they can cause ulceration. They can slip and then the patient can rebleed. But they're much better than using what was dying out as I first became a gastro registrar many years ago, which was ethanolamine, the sclerosants that you used to be able to inject, because they cause quite profound ulceration in the esophagus. But these are much better and they work very well. So that's what it looks like when you're doing a banding. This is looking, it's almost like looking down a kaleidoscope, and you can see that there's a bleeding point just here, which I guess is where they're aiming their, so what you do is you suck the tissue into this cap until you get, everything just goes pink in the screen, as you've got tissue right there, and then you just fire off a band, and that ties off the, ties off the vein. So moving on to peptic ulcer disease, what is it? It's essentially a mucosal break. Usually in this country it's caused by non-steroidals or aspirin. H. pylori is still around, but much less common. And as I said before, it's the most common cause of an upper GI bleed. So what we see at an endoscope is a nice clean base here, a low risk ulcer. You can see the break here, and then you can see visible vessels down here. That's what this is here, and again that is a risk for a greater risk of bleeding, and you can see active sort of oozing of blood on that ulcer there. So all of these, that is a low risk that may not need an urgent rescope. This is the sort of thing that does need treatment, and that probably wouldn't require treatment, that just needs documenting. So just to labour the point, in terms of rebleeding risk, it's pretty straightforward. If the artery is in that you can see is actively bleeding, if you don't treat them, then the rebleed rate obviously is going to be 100%. And you go down to the clean-based ulcers, the risk of a rebleed is around about 3%. And so it's pretty logical stuff. If you see an ulcer that's oozing, you've got a 1 in 4 chance it's rebleeding, you may want to treat that. So all of these the top 4 categories all need some form of endoscopic therapy. So just for a bit of fun, this is normally done face to face, but any thoughts into what the diagnosis is here, or the picture on the left? That's an angiodysplasia. I'm not sure whether that's what you're all shouting at me down the over the Teams, but that's an angiodysplasia. And on the right here, any thoughts for a second? That is called watermelon stomach, or gastric antral vascular ectasia, and it's the descriptive term is quite good. You get these sort of very fleshy tissue with the antrum, that is the pylorus, that's the outflow of the stomach there, and you get this this very fleshy tissue here, which is just superficial blood vessels, and that is a cause of chronic iron deficiency anemia and the occasional acute bleed. It's associated in about 1/3 of times with portal hypertension. So you might have somebody with varices, and indeed I did the other week, I scoped somebody who had varices and this. Both of these can be a cause of GI blood loss. Okay, what is this? A cause of obscure GI bleeding. If you know your French eponymous names of syndromes, this is called a Dieulafoy lesion. And it's a superficial arteriole, so it's a little vessel that comes up to the surface of the gastric mucosa and dips away again, and it can be just damaged by acid. You don't often see, rarely do you see something like this, but you might see this from time to time, and that is something that can be treated quite simply with a clip. Dieulafoy, as I said, large caliber arteriole. I will move on from that slide. So this is your Friday night special in A&E. This is the 25-year-old male who's had far too much to drink and has vomited and vomited and vomited, and then brings up some blood as he's caused himself a traumatic tear at the bottom of the esophagus. These are low risk. That looks quite spectacular. That looks like a lot of blood, but in reality, because the tissue is healthy in the first place, these often stop bleeding spontaneously, and rarely is there anything actually required to be done endoscopically, but it's worth documenting that they are in fact there. So does endoscopy affect outcome? Well, I'd like to think so, and indeed the study suggests that it does. So we don't just scope people because we can. There is a significant reduction in rebleeding rate. There's a significant reduction in surgery, and there's a reduction in mortality also. What we tend to do, and you can see this paper is quite old. These stats haven't really changed very much over all these years. So we tend to, if we're going to treat patients, just a little bit about endoscopy, we tend to use two modalities to treat. So we usually inject adrenaline, although you can just, there's a combination of the effects of the vasoconstrictive effect of the adrenaline plus the tamponade as well, of injecting fluid makes the difference. And indeed, we would want to put a clip or thermal methods onto these ulcers as well. So it's more effective if you use dual therapy. There's less rebleeding, less surgery, less mortality if you use more than one method to treat a patient. We have little clips that we can put down a scope, and they fire off. You can see here, obviously somebody's used 3 clips to inject, to treat an ulcer. We also use this to treat sort of post-polypectomy bleeds and various other things and close little defects. And they're useful little devices that are quite strong little clips that stop bleeding. As I say, using these clips, let's say, reduces rebleeding, surgery, mortality. We have also a thing called a gold probe, which is a device which you can inject with, and you can apply heat, and it's the combination of the adrenaline and then also using heat to cook tissue, coagulates vessels and helps stop any gastrointestinal bleeding. A very useful device, particularly in elderly patients with fibrotic ulcers, where you can't put, you can imagine putting if you put a clip on one of these clips here, they can shear, they can tear the tissue if it's very fibrotic, if it's not pliable, whereas something like that is, you cook tissue and it just stops the bleeding. So it's quite useful. And then we have what's called argon plasma coagulation, which looks like this if you do it properly. It's a device where you fire argon gas down a catheter and ignite it at the tip, and it causes these very superficial burns. Good for things like the watermelon stomach I showed you earlier, and for treating little superficial angiodysplastic lesions, little superficial vessels. So thermal methods, again, the studies would suggest that it does work, and it reduces mortality, rebleeding and surgery. Are there complications of what we do? Well, yes, there is, especially with using thermal therapy. We can cause perforations in gastric walls, and that's been demonstrated in studies that there is a risk of it, but it is not a significant risk, and it's much more outweighed by the benefits. So for the ever so occasional perforation that you may cause, you will do an awful lot of good in using this sort of stuff appropriately. So moving on to after the endoscopy. There is evidence, and again, data from Hong Kong, where all the studies were done many years ago, giving 72 hours of IV PPI continuously to raise the pH of the stomach allows for clotting to develop, allows for fibrinogen and platelets to do their job. And so we would tend to give 8 milligrams per hour for 72 hours, and it reduces rebleeding rate and reduces length of stay in hospital, but no significant reduction in the surgery or death or in these studies. But I'd say this is quite old studies, but I think the data is still relevant and we still use this protocol. When do we restart aspirin? Again, this is important to get, and I guess the same goes for things like the clopidogrels and other blood thinning agents, is that you do want to get patients back onto their blood thinners if you can. Obviously, they may well be on them for a very good reason, and it has been demonstrated if you leave these patients off, there is an increase in death in patients post-GI bleed because of the other cardiovascular things that they were taking these drugs for in the first place. So you get patients, so I tend to look at restarting these drugs as the patient leaves hospital. If they're inpatients with their bleeds, you want to get them back on these medications as soon as you can, because actually it's whilst it may increase the risk of bleeding potentially, actually it makes more sense that the patients have their cardiovascular risk managed. So are there any questions anybody wants to ask at this point?
Dr. Mayhead, I had a quick question.
Yeah.
I've come across capsule endoscopy, and I've never quite understood what the difference is between that and a normal one, and when it would be indicated.
Well, as it happens, I have a capsule here. So if you can see that, that is, that is a capsule. So what it is a little camera that tumbles down through the guts and just snaps away and takes images and sends it to a data recorder. So it's it doesn't treat things, but looks for, it's primarily evolved for looking at things in the small bowel, as opposed to stomach or colon. And it's just a device that allows you to get access to for obscure GI bleeding potentially, or to look for things like Crohn's disease and ulceration within the small bowel. You can pick up polyps with it. So it's quite a different technology. Patients like it because there's not often any prep, and they have to just simply come to the hospital, swallow a capsule, and then go home again. And the capsule just spends the day going through the small bowel, and then they return the data recorder at the end of the day. And it's a pretty safe test. The risk is the capsule being caught or retained on something, so you do want to make sure that the patient doesn't have a history of that might suggest strictures. So its role in GI bleeding, which I suppose is the topic of today, is for after. So you would do something like this if you've got to do a capsule, if you've got a patient who has had upper and lower GI endoscopy and hasn't found the cause of their melena, but they are still bleeding, and doing a capsule may identify a source of blood loss within the small bowel, which you can then go and chase with what's called double balloon enteroscopy. Which is a way of delving deep into the small bowel using a device with a scope with balloons on the end to act as fulcrums to drive the scope into the small bowel. So it's a useful test because it's relatively low risk, or it's very low risk, and it's quite non-invasive in that, and there isn't much prep, and that's what a capsule pill camera does. Is there any other questions?
There's a message on the chat.
Hang on a minute. Where's the conversation? Where is it?
Do you want me to read it out?
Is this the one for patients on warfarin?
Yes.
For metallic valves of GI bleeds, would vitamin K be needed to reduce the INR less than 1.5 TIS we mentioned when holding oral as well? For patients with metallic heart valves with a GI bleed, I think if you've got someone who's got a high risk, who's potentially high risk like that, if the INR is therapeutic, I would go and scope the patient. You can scope a patient with pretty much any INR. The higher the INR, the greater the risk of sort of bruising or trauma from the scope. But to be fair, if there's significant risk from stopping the warfarin, and I would say someone with a mitral prosthetic valve is one of those patients, then I would probably scope the patient with a therapeutic INR. Anything else? No worries. Okie dokie. I think, is there anything that anybody wants to ask about the services at ESHT in particular in relation to GI bleeds as opposed to GI bleeds? Is there anything sort of logistics related that anyone wants to ask? Fabulous. All right. Well, thank you ever so much for.
Thank you for
listening.
teaching when on annual leave. Really appreciate it.
Oh, no worries. No
Thank you.
worries.
Thanks, Dr. Mayhead.
Yep, no worries at all. Okay. All the best now.
Thank you. Bye.
Bye bye.